Our last distinguished speaker is Paul Hahn, Dr. Paul Hahn, a senior scientist at the National Cancer Institute. And his field of expertise is communication and medical decision making. And here he will talk about uncertainty tolerance and how to potentially reduce overdiagnosis. So over to you, Paul.
First, I want to just thank you, Ivan, and the SHE Center for this chance to be part of this webinar, to participate in this discussion, and definitely to the other three speakers for three really fabulous talks. And it's my privilege to offer some reflections to this discussion of overdiagnosis, which is an extremely important topic. I'm going to speak, well, first of all, here's a disclosure. I'm obligated to present as a federal government employee in the United States. So these views are my own and do not reflect my institution. I have basically three objectives that I want to try to accomplish in today's talk. And one is to discuss the relationship between uncertainty tolerance or intolerance and overdiagnosis. And I'm approaching this topic as a student of overdiagnosis. I don't consider myself to have a deep knowledge of this topic in spite of its importance, but these talks, as well as some recent literature, really prompted me to do some reflecting. But my remarks are going to be somewhat speculative, and I just want to sort of put out some thoughts more as a starting point, potentially, for some further work in the future. And I'm going to describe the nature and causes of uncertainty, tolerance, and intolerance in medicine as a way of talking about this potential connection between these two phenomena. And then finally, try to identify some opportunities and challenges for perhaps improving uncertainty tolerance in medicine, and as importantly, as a potential means of reducing overdiagnosis. So I want to start, first of all, level setting. I'm actually, thankfully, not going to dwell too much on trying to define overdiagnosis, since John and Alexandra included this content in their talk. And obviously, they represent leading scholars in this field. But I just want to put this definition that John actually mentioned. This is from his work in his talk, really just to sort of level set. And I'm not going to dwell on this at all, but just to sort of make sure that we're really starting from the same conceptual point here. As John talked about in further detail, there are two kind of overarching causes or types of overdiagnosis. And I think this is a really nice kind of overall rubric to orient our thinking in terms of thinking about both overdetection and overdefinition of disease. And then here's some potential causes that have been listed by John and Alexandra and other scholars in the field, that if we try to think about sort of root causes of overdiagnosis in medicine, what are they? And they have touched on these issues as Bjorn has as well. And they run the gamut from sort of conceptual issues. And then, as Alexandra pointed out, there's cultural and social factors that are driving many of these things. But I also want to point to this factor, uncertainty and tolerance, which has been identified by several investigators as also an additional cause of overdiagnosis. And because my own work really focuses on uncertainty and uncertainty tolerance, I wanted to try to drill down on this phenomenon and this purported connection between uncertainty, intolerance, and overdiagnosis, and talk about that a little bit more. First, I want to point out that this idea of uncertainty and tolerance certainly is something that that makes sense from a sort of common sense point of view when we think about what could be driving overdiagnosis. It's pretty easy to think about this phenomenon as really pointing to a fundamental inability to deal with uncertainty, whether it's diagnostic or other forms of uncertainty, and also view this as something that affects obviously clinicians, but also patients. And it's also easy to think about this as manifest at multiple levels. So at the individual level, there's a nice paper from back in the 1980s by Jerome Kasserer, who's a former editor of the New England Journal of Medicine, where he wrote about the stubborn quest for diagnostic certainty. And I think that's something that sort of, again, rings true on a common sense level, that we think that there's this sort of individual drive just to know more and to be certain about a diagnosis. And to also, we can view that as manifesting kind of an individual level uncertainty tolerance. And then we know there's other writers who have talked about a systemic uncertainty intolerance, that is a culture of shame and blame that really drives physicians in particular to order too many tests and to overuse medical interventions. And so these are, kind of uncertainty intolerance in this sense can then be sort of posited as a fundamental cause or a root cause of our diagnosis that really motivates people to engage in this act of assigning diagnostic categories to patients. And so it's a natural question to ask, I think, is this a promising focus? Is uncertainty intolerance a promising focus for efforts to reduce overdiagnosis? And I think in some sense, to answer that question, we have to think about what do we really mean by uncertainty intolerance? We have these common sense sort of notions of what it means. And there is a large literature on this in the social sciences, in psychology and sociology. And a prevailing definition or conception of uncertainty intolerance is that it's really an individual characteristic. It's a trait level characteristic of people that consists of a propensity towards negative or aversive psychological responses to uncertainty. At least this is the way it's been primarily conceptualized by researchers. And here's one definition by a leading researcher, Nicholas Carlton, who has developed measures of this, probably the most widely used measures of uncertainty tolerance in research. And he defines this as the individual capacity to endure the aversive response triggered by this sort of presence of or absence of salient key or sufficient information sustained by the associated perception of uncertainty. And there are about, last count, my colleagues and I did a systematic review of this literature several years ago. There are about 23 or so measures of uncertainty intolerance or tolerance, which is sort of the flip side of this. But essentially, they all share this quality of conceptualizing this as essentially this sort of negative responses to uncertainty. So the one question to ask when we think about a connection to overdiagnosis in particular is that is uncertainty intolerance alterable? Can we actually change it? Even though it's been considered to be mostly a trait level characteristic, can we actually alter it or improve uncertainty tolerance? Well, I think for one, to answer that question, we have to first consider what are the causes of that? What causes uncertainty and intolerance, and particularly in different contexts like medicine? And there's been some work on this as well. And going back to the 1980s, Jay Katz argued very eloquently that basically in medicine and both medical education and practice, there's been a historic disregard of uncertainty that ironically, even though we might consider medical care itself to be fundamentally dealing with uncertainty all the time, it's never called out and managed and treated explicitly. And this general disregard of uncertainty in medicine actually causes people to be intolerant of it. And then one can argue that in medical practice and in education, there's also been a kind of limited or narrow focus of activities and also the goals that we engage in as medical practitioners or medical educators, we tend to focus on curing uncertainty, that is, trying to eradicate it or reduce it. We focus on the objects of uncertainty, that is, what are the things that we're uncertain about, whether it's a diagnosis of a patient, a prognosis, a treatment, et cetera. And we also focus on what's causing uncertainty. What is it that is making what clinicians and patients experience uncertainty? And we also think more in terms of the cognitive responses to uncertainty. That is, what do I need to know? And how do I sort of get out of this state? So what are these cognitive responses? And then thirdly, I think we could argue that another cause of uncertainty intolerance is that we as clinicians have a pretty limited repertoire of strategies for managing and tolerating medical uncertainty, and they're predominantly ignorance focused. And I'm going to talk a little bit more about that. So when you think about the signature activities of medical care, a lot of them really focus on diagnosis, but they also are cognitive activities that are focused on information seeking towards the goal of reducing ignorance, achieving knowledge, and achieving certainty, that is the feeling of knowledge. And these are all the activities that we engage in, that medical students and residents are taught. And certainly much of this focuses on diagnosis, not all of it, but history and physical examination, diagnostic testing. These are all things that we do that are very primarily, maybe exclusively, ignorance focused. And again, they're all towards this curative goal. We need to just get rid of uncertainty by eliminating our ignorance. But these things really point to some deficits, I think, that you could argue are fundamental causes of uncertainty tolerance in healthcare. And the way that we would then try to improve uncertainty tolerance is basically to undo these three trends. So instead of, as Jay Katz argued, disregarding uncertainty, can we actually centralize it and make it explicit and call it out as a problem to be managed? And then secondly, if one cause of uncertainty and tolerance in medicine is a narrow focus, well, maybe we can broaden our focus, both in medical education and practice. And instead of focusing on curing uncertainty, we could focus on palliating it, that is, ameliorating its negative effects. We could, instead of focusing on what we're uncertain about the objects, we could focus on the experience of it. So what is it like to experience uncertainty, and how can we use that to sort of focus on different things to help people live with uncertainty? And then instead of focusing on the causes, we could focus then on the effects on both clinicians and patients, whether it's psychological, social effects. And this could be really more of a focus. And then we could also get away from the strictly cognitive responses and think about emotional and relational responses. How does uncertainty make us feel and interact with one another? So this could be a potential, way of improving uncertainty tolerance. And then finally, we could try to expand the repertoire of strategies that clinicians use to manage uncertainty. So instead of reaching for that test and trying to reduce ignorance, are there other things that we could do that are more palliative in nature? And what I want to briefly touch on is what those strategies might be. So several years ago, my colleagues and I conducted some qualitative research where we tried to we actually interviewed trainees and practicing physicians at all levels of experience to try to understand and also conceptualize what are the major kinds of strategies that clinicians engage in to manage uncertainty. And we ended up categorizing these into 4 groups. And one is ignorance focused, which we've already talked about. But the other types of strategies are both uncertainty focused, which aim not to reduce ignorance, but instead they aim to reduce or increase, or I guess you could put it more broadly, to adjust our metacognitive awareness of ignorance, which is uncertainty. Uncertainty, again, is sort of, it's not equivalent to ignorance, but it actually represents our awareness, our conscious awareness of ignorance. And there are some strategies that focus on altering or reducing uncertainty rather than getting rid of ignorance. And then thirdly, response-focused strategies aim to mitigate or ameliorate the aversive psychological effects of uncertainty. They don't do anything to reduce uncertainty or ignorance, but they actually aim to basically palliate our aversive responses to uncertainty. And then finally, relationship or person-focused strategies are all about sharing uncertainty, sort of distributing the burden of uncertainty, or providing human presence that can help people manage uncertainty. And we kind of broke this down, and I'm not going to talk in detail, about this, except to say that these are, again, this is where typical medical practice and education is at, which is ignorance-focused strategies. But if you think about the broader array of more palliative strategies that can include both uncertainty-focused strategies, as I mentioned, and then and response and relationship-focused strategies, these could perhaps provide clinicians with a broader repertoire of responses to uncertainty that might be alternatives to the typical ignorance-focused strategies, and may thereby reduce things like overdiagnosis. Now, the problem is that this has to be only the tip of the iceberg. Alexandra's comments about culture and environmental context, the structures and processes of healthcare, is really, I think, salient to the point that I want to make here about really the major challenge of this idea of improving uncertainty tolerance in medicine. And that is that, first of all, there are sort of sources of uncertainty as well as uncertainty intolerance that are well beyond the individual. We tend to sort of, and this is the way it's been conceptualized in the behavioral research literature, as a sort of uncertainty intolerance is an individual characteristic. It's very kind of intrapsychic. It's a phenomenon that needs to be addressed, by individuals. That's true to a certain extent, but we also know that there are system-level sources of uncertainty and uncertainty tolerance that lie at the sort of institutional, socio-cultural levels. And then, in essence, if we're talking about improving uncertainty tolerance, we're talking about the need for culture change. We have to change the culture of medicine. And I think the second point is that there are deeper and broader meanings of uncertainty tolerance. And it's been conceptualized in psychology and in the behavioral science world as this sort of capacity to deal with the negative psychological aspects or responses that we generally have, to uncertainty. But if you think about it, if the absence of negative responses like fear or indecision or vulnerability, if that's what uncertainty tolerance really means, I don't think we could live our lives. That there's a sense in which these negative responses to uncertainty can actually be adaptive and good. And moreover, there are actually positive functions of uncertainty. We need uncertainty to maintain hope, for example. And so that we need a larger concept of uncertainty tolerance in a normative sense that goes beyond the sort of absence of negative psychological responses. And I think we need to think about uncertainty tolerance more as a capacity for adaptation, or to reach an adaptive balance between different responses to uncertainty that enable people to respond adequately to a situation. And that's a much fuzzier, problematic concept, but I think that's what we need to do. And we need to think about uncertainty tolerance really as a fundamental orientation towards uncertainty, and that allows us to sort of normalize the experience, and also perhaps to even leverage it for the benefit of a person in a particular situation. And then finally, there's a lack of effective interventions to improve uncertainty tolerance, both in medical education and practice. And these are all huge, I think, challenges to the idea of improving uncertainty tolerance. Having said that, I think that there are some promising starting points, and that this is something that I think we need to really try to address as a medical profession. and both at individual as well as system levels. And I think ways to do that, and this is what I'm trying to do with my colleagues like Ivan and others, while I'm here in the coming year, is that we're trying to think through ways of developing strategies and learning and teaching strategies in medical education where we can actually help learners to develop sort of both greater consciousness and understanding of uncertainty and different management strategies, but also practical skills that they can handle uncertainty, whether they have to do with communication or building the capacity to tolerate uncertainty. And by that, I mean tolerance in a larger sense. And we think it comes down to ways of promoting and nurturing different virtues and value orientations. And we're kind of thinking about ways that we could actually integrate this into medical education. And then in clinical care, some of these things have already been talked about by many scholars, things like shared decision-making, which I think you could view as really an exercise in shared uncertainty. And are there ways we can actually successfully implement shared decision-making in practice, which is a big, big challenge? But also, are there ways that we can rethink structures and processes of care that actually encourage reflective practice and that help people kind of acknowledge and normalize uncertainty and get away from this sort of culture of shame and blame that people have pointed out? And I think that also means trying to build structures and processes for provision of emotional and relational support. So I just want to end by really kind of putting a question out there that I think that there is a connection between uncertainty, intolerance, and tolerance, and overdiagnosis, and that this idea that if we could improve uncertainty tolerance, we might reduce overdiagnosis, I think is a promising idea. Having said that, it's a really big challenge, and I think it involves not only expanding the repertoire of management strategies that clinicians might use, but really fundamentally or changing their fundamental life orientation toward uncertainty, which is sort of a deep and big prospect. And also intervening at both individual as well as system levels. And this, I think, is an enormous challenge, but I think it's also necessary to address. And this is something that I hope we can kind of think about together in the future. So finally, I just want to say thank you to you all and to the U.S. Norway Fulbright Foundation, as well as my very thoughtful colleagues here in Norway, and hopefully new colleagues that yet to come in my experience here. But it's been, a tremendous opportunity to be here around so many great thinkers, and I look forward to further discussions in the future.